Hello everybody, welcome to number 1 Doctor channel. Today's video is about ulcerative colitis, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like, share our videos, subscribe to our YouTube channel number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about ulcerative colitis. Unlike Crohn's disease, ulcerative colitis affects only the colon, and whilst Crohn's disease affects the full thickness of the bowel wall, ulcerative colitis affects only the mucosa. Another difference from Crohn's disease is that UC usually affects the colon, and as the disease gets more extensive it spreads proximally in a continual pattern, i.e., skip lesions should make one consider Crohn's disease. Like Crohn's disease, UC is a chronic and relapsing condition. The normal mode of presentation will be of blood-stained diarrhea and abdominal pain, which is often eased by defecation. Note: UC tends to present with blood and diarrhea, whereas Crohn's tends to present with painful diarrhea. In most cases there are no abnormal physical signs. In more severe cases, nausea, vomiting, and distension may occur in association with pyrexia, and this should make one suspect the development of toxic megacolon. In non-acute cases, investigation consists of the elimination of other pathologies, and confirmation is usually made by biopsy on sigmoidoscopy or colonoscopy. It can sometimes be difficult for the histologist to differentiate Crohn's from UC, and may call the condition as indeterminate or non-specific inflammatory bowel disease. The other major difference between Crohn's disease and UC is that while the former appears to have only a small premalignant potential, the latter is most definitely premalignant. The figure usually quoted is that for ulcerative colitis involving most of the colon, there's a 10% risk of developing a carcinoma for every 10 years that the disease exists. Because of this, people with UC are advised to have regular routine screening colonoscopies with biopsies every 2-3 years. The particular feature looked for on the biopsy is the development of dysplasia, and if it is severe, consideration should be given to the possibility of the majority of UC patients, 85%, can be managed medically. Antidiarrheals, steroids, mesalazine, etc. Unlike Crohn's disease, in which about 65% will require surgery at some point, the principal acute complication of UC which you need to know about and which might require surgical intervention is toxic megacolon. This is diagnosed on a plain X-ray and is defined as dilatation of the transverse colon above 6 cm. The patient will normally be quite well with UC and will present with severe blood-stained diarrhea and systemic signs such as fever, dehydration, and tachycardia. There is usually abdominal tenderness and the white cell count may be raised. Initial attempts will usually be made to treat the patient conservatively with intravenous fluids, correction of electrolyte abnormalities, and high-dose intravenous steroids. Repeated abdominal X-rays should be taken to watch the size of the colon, usually the transverse colon, and if it appears to be getting bigger despite appropriate medical treatment, an operation is indicated before it perforates. Also, if a perforation is suspected or if the patient fails to settle within 24-48 hours of medical treatment, then surgery will be indicated. In this situation, the usual surgical procedures, a total colectomy, an ileostomy, and the rectal stump is usually oversewn or brought out to the skin so that it can be inspected. This is called a mucus fistula. Subsequently, when the acute problem has settled, the patient could be offered an ileal reservoir or completion proctectomy, i.e., removal of the rest of the last part of colon, leaving the patient with a permanent ileostomy. According to discussions between the surgeon and patient, it is not uncommon to be shown a barium enematoma during your viva, an elective total colectomy to reduce the risk of cancer formation. The operation will normally be a proctocolectomy, which means that the whole of the colon will be removed so that no colonic mucosa will be left. After this, the patient either is left with a terminal ileostomy or can have a new pelvic reservoir, a pouch constructed, which is made by joining several loops of small bowel together and sewing that directly down to the sphincters. A pouch operation would nowadays normally be offered to any person requiring a total colectomy for UC. Such an operation cannot be offered to patients with Crohn's colitis, because Crohn's disease often recurs in the small bowel used to construct the reservoir, and the results of the operation are therefore poor. and the commonest diagnoses are ulcerative colitis or an apple core stricture indicating malignancy. You may also be shown a barium meal with follow-through which looks at the small bowel. You see some contrast in the stomach and hence you can tell is a follow-through, and this may show the strictures of Crohn's disease. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. Number 1 Doctor.